Being a psychostimulant agent, amphetamines expedite the transmission of the signals from the body to the brain. So, the chemical formula of the amphetamine is C9H13 and N, which means it consists of an amino group, a methyl group, and also a benzene ring group. And it is under the class of CNS stimulant and sympathomimetic agent. Apart from that, amphetamine is also under the class of beta-phenethylamine. Additionally, it is the parent compound of the substituted amphetamines, which is a structural class that includes a well-known drug such as methamphetamine, bupropion, cathinone, and methylene dioxymethamphetamines. So, the common street names for the amphetamines include bennies, black beauties, crank, ice, speed, and also now I'm going to explain about the background study of the amphetamine. Well, the drug amphetamine was discovered in the late 1920s, 1930s, and also 1940s, where the researchers thoroughly examined its pharmacological effect, especially on attention, cognition, emotion, and appetite. By 1947, amphetamines has three beneficial pharmacological action, which includes enhancing the mood, suppressing the appetite, improving attention, as well as the new one cognitive function, which had been thoroughly investigated in meticulously controlled trials. So, since the drugs were widely used for non-medical purposes, the medicine realized they could be abused. So, there has been a strict international control over them since about 1970. So, as tricyclists and monoamine oxidase inhibitors will begin to compete with the amphetamine and methamphetamine as the antidepressants, weight loss emerged as the most common and accepted indication of these drugs by the late 1960s. By the early 1970s, the amount of pharmaceutical amphetamines consumed annually in the United States had increased to approximately 50, which means 10 milligram tablets per man, woman, and even child.
Amphetamine is indicated for the treatment of attention deficit hyperactive disorder as well as for the treatment of central nervous system disorders such as narcolepsy. ADHD is a complex disorder associated with substantial heterogeneity in etiology, clinical presentation, and treatment outcome. ADHD comes from a complex interplay between the interdependent genetic and non-genetic factor which cause a complex mental disorder in the children as well as teenagers. On the other hand, narcolepsy is a chronic sleep disorder typically present during adolescence and characterized by excessive daytime sleepiness. Amphetamine is also being used nowadays off-label for the treatment of obesity, depression, as well as chronic pain. For the section dose and dosage form, adult patient with ADHD disease, for their immediate release, the initial dose will be suggested a 5 milligram orally tablet 1 to 2 times a day. As for the maintenance dose, daily dose may be raised in 5 milligram increment at weekly interval until an optimal response is obtained. For the rare cases, the dose can be accessed more than 40 mg per day. For the immediate release as well, the first dose should be given upon awakening and also 1 to 2 additional doses should be given at the interval time of 4 to 6 hours. For the patient starting treatment for the first time or switching for another medication can use the extended release tablet where the initial dose will be 20 mg orally once a day. Where possible, the drug administration should be interrupted occasionally to determine if continued therapy is required or not. For the adult who have narcolepsy, for the immediate release tablet, the initial dose will be 10 milligram orally per day in divided dose. As a maintenance dose, daily dose may be raised in 10 milligram increment at weekly interval until optimal response is obtained. The first dose should be given awakening and also 1 to 2 additional doses should be given at interval time of 4 to 6 hours. The usual dose is 5 to 60 milligram per day and is divided dose depending on the individual patient response. If the dosage given causes any adverse reaction like insomnia or anorexia, the doses can be reduced. As for the mechanism of action, it is important to us to consider that amphetamine has a very similar structure to the catecholamine neurotransmitter, mainly on the presence of the long planar conformation, the presence of an aromatic ring, as well as a nitrogen in the aryl side chain. Amphetamine, as well as the other catecholamines, is taken into presynaptic nerve terminal by the association with two sodium ion and one chloride ion. The complex of amphetamine with the ion is actively transported by monoamine reuptake transporters. As amphetamine act competitively with the endogenous monoamine, the greater number of amphetamine, the more internalized amphetamine will be found. Once inside the presynaptic terminal, the amphetamine displaces other monoamine to be stored by VMAT2, which produces the pumping of the neurotransmitters into the synapses by the process called retrotransport. This process of release of neurotransmitter is approximately fourfold more potent in the D-isomer for the release of dopamine. The mechanism of action of the amphetamine is complemented by the inhibition of the reuptake and of monoamine oxidase, which acts synergistically to produce a significant increase in the monoamine concentration. Activity is not done as an inhibitor but more as a competitive substrate, and thus amphetamine is known to be a weak dopamine reuptake inhibitor, moderate noradrenergic reuptake inhibitor, and also a very weak serotonin reuptake inhibitor. From this specific action, the L isomer is known to be significantly less potent. Lastly, amphetamine is known to be an inhibitor of mitochondrial bond enzyme, which is a catalytic enzyme in charge of degrading all the excess neurotransmitter. So the mechanism action of this amphetamine often overpass, as amphetamine is a very weak MAO inhibitor, but this mechanism
Well,
cannot
now
be
I'm going to
dismissed.
explain about the abusement of amphetamine. Usually, amphetamine is taken orally or injectable, but adding ice, which is a colloquial term for crystallized methamphetamine hydrochloride, has encouraged smoking as an additional method of management. So, the same way that crack is for smoked cocaine, the malleable methamphetamine is known as ice. Based on the data.gov.my, which is a statistical regarding the drug abusement and also the drug addiction in our Malaysian country, it has been reported that the amphetamine abuse among people is about 4,166, which is the second highest. And particularly, the male population has been prone to this addiction. And it has also been recorded and reported that the secondary school students are more addicted to amphetamine drugs. So, the factors that lead to the amphetamine abusement are, first of all, dependency on the drug. Due to its pharmacological action, as it mentioned earlier, which is enhancing the mood and suppressing the appetite for weight loss, people are more prone to use it and it become an abusement nowadays. Moreover, addiction to this drug would also be another factor, as the dependency and also the addiction are interconnected to each other. Not only that, the family and peer also influence for the drug abusement, as we have heard with many newses. The family, either the father or the mother who are a drug addict, might influence their children to take the drug. And especially in peer, which means in secondary school, the one with a lack of educational background might influence their another friend to get addicted to this drug, as we can see based on the statistic. So, the post-traumatic stress disorder also another factor for the drug abusement. This is due to its pharmacological action, where it will enhance the mood, which causes the victim to overcome their stress due to their past trauma situations or events.
As for the pathophysiology of amphetamine abuse, which mentioned that the amphetamine stimulate the central and peripheral nervous system, they can cause an increase in biogenic amine that originated from the neuronal synaptic terminal, which in turn inhibit the reuptake of certain neurotransmitter. Amphetamine also a lipid soluble, therefore they can cross the blood-brain barrier rapidly after being injected or ingesting. Amphetamine can increase the activity of neurotransmitter dopamine and also norepinephrine. However, they also can induce the release of epinephrine, serotonin, as well as histamine. The elevated serotonin level can affect the hypothalamus and can cause the hyperthermia. Increases in dopamine level in CNS can cause psychosis, euphoric effect, and other movement disorder. Amphetamine toxicity can also cause seizure due to the neuronal death from the interaction between amphetamine and an NMDA receptor. Catecholamine levels are elevated in the amphetamine overdose, causing increase in energy, increase in stimulation with decreased lethargy. Tachycardia and other arrhythmias conditions are due to the symptomimetic effect of amphetamine. Amphetamine can cause tachycardia and hypertension and can cause significant cerebral blood flow, which increase by 30%. This is seen particularly in the left frontal cortex, which can lead to hemorrhages and other forms of strokes. Several studies have concluded amphetamine abuse is strongly associated with coronary artery disease. And the long-term use of amphetamines is associated with many conditions like myonecrosis, cardiomyopathy, myocardial infarction. The amphetamine abuse associated with many withdrawal syndrome. As for the initial phase of withdrawal syndrome occur as the stimulant effect wear off. The symptoms include prolonged sleeping, depressed mood, overreacting, or even some cravings. So the initial phase may last only 1 to 2 days, then be followed by a longer period of symptom that can last for days or even weeks. So these include mood changeability, which means we have depressed, inability to experience pleasure, and etc. Cravings, disturbed sleep, and lethargy. Psychotic symptoms may emerge during the first 1 to 2 weeks. So the amphetamine withdrawal is largely subjective but may be very difficult to manage, particularly for the friends, family members due to the mood swing. As for the management of amphetamine withdrawal syndrome, this includes uses of medication. Even though there's no medication demonstrated to be effectively in elevating the amphetamine withdrawal syndrome, but some medication may be useful with some symptoms. We started off with the antidepressant have been used for withdrawal-induced depression with some benefit, although the onset of action of its delay and relapses to be used while taking antidepressant can result in hypertension or even serotonin syndrome. Next, we're going to see is mirtazapine. Maybe can be continued for the depression symptom if responsive to treatment is evident. The short-term use of benzodiazepine and antipsychotic for control of irritability and agitation can be helpful. Care should be taken to limit access to large quantity of this medication and to avoid any development of benzodiazepine dependence. This medication should be prescribed for a maximum day of 7 to 10 days. In conclusion, amphetamine abuse poses a significant public health concern impacting individuals, families, and communities. This assignment has shed a light on the prevalence, consequences, and contributing factors associated with amphetamine abuse. It is evident that the multifaceted approach is necessary to address this issue comprehensively. To overcome the amphetamine abuse, a combination of prevention, intervention, and treatment strategy is crucial. Treatment options including medication to overcome the symptom posed by the withdrawal syndrome. As for the therapy treatment, including the family counseling, education, or even cognitive behavior therapy. That's all from us. Thank you.